today we have with us Dr. Amitav Banerjee, who is currently a professor and head of community medicine at D.Y. Patil Medical College, Pune, and was formerly an epidemiologist with the Indian Armed Forces. Today's interview is basically a part of a series of interviews which we are conducting on behalf of PAPH, People's Alliance for Public Health. So we welcome Dr. Amitav Banerjee in today's show.
Thank you. It's a pleasure to be on this platform.
Thank you, sir. So let's move on to our questions. So, Dr. Banerjee, you are known to have uttered time and again that management of this pandemic should have been in the hands of the epidemiologists. However, it is actually clinicians who have led the response to this pandemic. Now, in what way do you think that this enhanced role of clinicians have led to a pandemonium?
This thought I had earlier in the pandemic. In the first year, I thought this would have been handled by epidemiologists rather than clinicians. And after 2 years, I have refined it further. It should have been handled by epidemiologists from Indian countries or other developing countries who have got more first-hand experience of managing infectious diseases. What has happened is, over the years, the developed countries, the Western countries, they have lost contact or first-hand experience with communicable diseases. So their epidemiologists also are more familiar with non-communicable diseases, which doesn't spread very fast, which has a different dynamics. Whereas communicable diseases are not easy to control, they spread from person to person. And secondly, clinicians, even in developing countries also, clinicians, particularly they are in tertiary care hospitals, in high super specialty hospitals or big hospitals, they are handling very serious cases, because by selection, only the serious cases land up in big hospitals. So they get a different perspective. They get a exaggerated severity of any infection. Whereas the majority of cases in the community may be very mild, which actually happened with the COVID-19. When the sero surveys were done, it was found that very few people land up with severity and death, and those also have got certain other risk factors. So that clinician looks very piecemeal the problem, and if the clinician they are very popular because it's a very glamorous clinicians in high tech hospitals. So the policymakers, the politicians, the public at large, they feel that they have answers to everything. And in good faith, the clinicians, all their practices with very serious cases, so they extrapolate that perhaps if the preventive measures or serious measures or active intervention is not done, many people will die. So this was something with good intentions, but different wrong perceptions. So this is what I feel. We are the largest population after China. We have got the largest doctors who go all over the world to serve. We should have been leaders in communicable disease control. We still blindly imitate the Western countries who have got different demographics, and their doctors do not have first-hand experience. They cannot treat a simple case of malaria. They have not seen a case of other communicable disease. So they are making the policy and the world is imitating them. And that is caused to this disaster. With our workforce, with our talent, we should have been leading the fight against communicable disease, and we should gain back the confidence which perhaps we never had.
Okay. So, sir, let's go to our next question. We have experienced that whole district hospitals, tertiary care government hospitals have been converted to COVID hospitals, leading to many-fold increase in the distress of the people in getting hold of the meager resources of healthcare delivery services. What is your experience regarding the same from your end in running of the control programs for other infectious diseases or those of malnutrition?
Exactly. This is the fallout of the initial loss of perspective. As I said, the Western model of the self, they do not have many communicable diseases. So for them, it may have been important, firstly. Secondly, they have a high elderly population. There, perhaps this is a major. Whereas our demography is different, we have got very younger population, or our younger population, they have got more other communicable disease. They take a very heavy toll compared to COVID. Every day, young people die of tuberculosis. 1,400 people die of tuberculosis every day. We have got a dengue, we have got typhoid, we have got Japanese encephalitis in many parts of the country. So when the Western countries, they made the beds available only for COVID, we followed them blindly, not understanding the repercussions it will have. Because even in the best of times, when there are no special reservation for any particular disease, or public hospitals are overcrowded, they are overcrowded, and reserving this and stopping other treatment aggravated the situation many times more. Every day there are so many deaths from other diseases that number of deaths or total deaths, other diseases got neglected. People died of people after some time. The people were afraid to go to hospital because of COVID, so they did not take early treatment for strokes. They did not take early treatment for heart disease, and many people might have succumbed to this neglect indirect effect.
Okay. Uh, in your experience, uh, or rather, we all have seen that in this pandemic, the lower strata of the society has paid the price of security of the privileged sections. So, what is in your experience the effects of this pandemic over the different classes of the population?
Exactly. This is a very good question. In fact, there was a article, I think, in Lancet, or it's a viewpoint in Lancet, or I think in BMJ. The first year of the pandemic, the author says that the restrictive measures like lockdown and other things are the price which the poor pay in poor countries to save the rich in developed countries. So similarly, inside India also, we are a very large country. We have got diverse socioeconomic strata. We have the richest of people, we have the poorest of people. And the brunt was borne by the poor people in a manner which did not help them. They were never at risk because most of the poor people, they are young. They do not live to very age, like 80s and 90s, which are the actual vulnerable people for COVID. So they are young people, and even if they live to 80 to 90, the poorest strata, they have got immunity because they have been exposed. The immune systems are very good. They are exposed to so many infections, and the very fact they have survived, nothing happens to them, even with a minor coronavirus infection. And secondly, these restrictions, this lockdown, were blindly applied from the West, whereas all social conditions are different. That is, we neglected the social epidemiology. We have got a 10 times, 20 times more population density than the European countries. And we have got in a slum or in a tenement, in one room, 10, 12 people stay. And if they are working throughout the day, they are dispersed. If their lockdown is there 24 hours, they are more crowded, more dense. In fact, the infection will spread faster. And that's exactly what happened. They, in the first wave only, they got the herd immunity. Upper class were left vulnerable, and it did not help them. Unfortunately, some misinterpretation of data, like outdoor transmission is negligible. Most of our poor people are in the unorganized sector. They are selling something on the, they are vendors in the thela, they are selling their fruits, they are working outdoors. There is no transmission outdoors. And by lockdown, they have been brought indoors, just the opposite of what you are supposed to achieve. So, and I say that social distancing is actually which happened in India. They say that social distancing is a bad word. You should say physical distancing. But this social distancing happened. The rich became richer, the poor became poorer, and they suffered more, and the rich people did not suffer at all. So this social distancing is actually, in actual practice, social distancing occurred in India.
Yes, that's true, and that is a harsh reality of our country. So, sir, you have cautioned time and again about the fact that, in view of the high prevalence of seropositivity, universal vaccination is unnecessary. Can you explain this in a layman's language?
This is actually, I just fail to understand. In high school, we learn this. In high school, we learn that a person who gets a viral infection, they develop immunity. We have seen since our childhood days. Person who gets chickenpox does not require a chickenpox vaccine. A child who gets measles does not require a measles vaccine. So we have seen this, and questioning this and saying that no, we are not knowing, and uh, we want a vaccine to have a confirmed immunity. Vaccine is also new, but the natural immunity is known for ages. So you are trusting someone unknown vaccine over a known natural immunity phenomena which we know from ages. So it is something like you don't trust your wife, but you trust your mistress. So this is something loving, never love a stranger. So this is what happened. And if you see the phenomena now, you see after the second wave, almost 70% of our population had antibodies, and that is an indirect measure that the virus has run through the community, antibodies, because after some time the antibody levels disappear, but the T cell and memory cells are active. So if at a given point of time, let us, I think in June 2021, they did a survey, they found 67% adults and even 65% children, they had the antibodies. That means over 80% of people must have experienced, because at that some people must have antibodies, must have come down. So almost 80% people. And subsequently in September, they did a sero survey. September last year, they did a sero survey in children below 18 years. That time they found 82% children. And in September last year, the vaccination was not started in children. Therefore, without vaccination, also people got the natural infection. And the sero survey in June also showed 67% positivity in adults and 65 or 60% in children. So there wasn't much difference between the children and adult dynamics. So if 80% children in September had the antibody, you can expect that the natural. Subsequently, they have been questioning the natural immunity. We don't know why. At least what they could have done if they had wanted to follow the science is that follow these people who have recovered, don't vaccinate them, and those who have not had the antibodies, give them, and then see. We would have saved money. I'm not talking of side effects. The amount of money, 36,000 crores spent on vaccination. This is the money for a thing which may perhaps have not been needed. And secondly, this was okay. This was on a premise that we don't know anything about natural immunity. Subsequently, studies came from Israel that people who have recovered from natural immunity from other parts of the world, also from Cleveland Clinic, USA, from Israel, that the person who has recovered from natural infection has got 13 to 27 times more robust immunity compared to the vaccine immunity. That means a person had got 11 to 25 boosters already, 1 and 2 dose and boosters. So that he had evidence, a very large population survey from Israel, very large, larger than any vaccine trial, and also which substantiate the earlier knowledge about natural immunity. So I didn't know where is the doubt. We could have waited. And another thing which we are doing with this mass vaccination is that we are removing the evidence of benefit as well as side effects. You see, vaccines are unknown vaccines. There have been concerns that the spike protein may keep multiplying, damage some organs. There have been anecdotal cases of myocarditis. Myocarditis, of course, is not anecdotal anymore. There have been reported cases of strokes. So the risk benefit, and now what happens now? we are talking of long COVID. So if you have kept a uncontaminated group to follow up, that those who have just recovered from natural infection need not vaccinate them. There is no ethical issues because as the evidence shows, they are 13 to 27 type protected. Follow them forward. If there are any adverse effects compared to the vaccinated group, then you will know whether this is due to the natural infection, long COVID, or adverse effect of vaccine. And another thing they are doing now, which is again, which does not stand to reason or science, is they are saying that if you have taken a primary doses booster, you can take some other vaccine. Different vaccine companies have come. If you have taken this from say Covaxin, you can take Covishield booster, and some new vaccines are market is likely to expand. Different, even mRNA vaccines are trying to come to India. So if you keep on mixing the vaccines, if there is a side effect, how will you know which vaccine is causing the side effect? And how will you know whether it is natural infection is causing the long COVID or the vaccine is causing the long COVID? So we are, this is something, and all these are in trial mode. So we are not following the protocol for a good trial also.
This is a great situation indeed. During the first wave of COVID-19, the term R0 has emerged in public use. It has been claimed that it is an index of infectivity. Can you enlighten us on this matter?
What is the index? R0. Okay, R0. You see, this is again a thing which the Western epidemiologist may just blindly follow. R0 is something like if a person is infected and his family or his contacts, if he doesn't infect anyone, that becomes R0. If he infects one person, that means R1. If one infected person infects 2%, that becomes R2, R3. And if we say R1 is more than 1, means it will spread, because 1, 2, 4, 1, 2 ka 4, there is so. And if the person does not infect more than 1%, it will become endemic. So this is a valid measure of infectivity only in the initial phases, very early phases of a pandemic or a outbreak. Because what happens after some time, like particularly in COVID, many people develop the immunity, which may be due to asymptomatic infection. So this value which you make, like initial in the epidemiologists, they must have felt that one person infecting 3 others, because everybody was susceptible in the household, and particularly in the Western countries, it struck the nursing homes first. Elderly people have got less immunity and all crowded together. So one elderly got infection and 5, 10 affected. So very high R value was coming, and they extrapolated this. So R value depends on not only also depends on the age of the contacts, the immune status of the contact. So there are many variables. So, and particularly in say country like India, where they are very dense population, there may be infection with other coronaviruses. So there may be some cross immunity, or many people will simultaneously get subclinical infection. So R value in the Western countries will not apply R value in the Indian countries. It is like, you see, when you buy a car, new car, the manufacturer says it will give you so many 25 kilometer per liter KPL, and then small print पे रहेगा कि under test conditions. And when you take a car and in the traffic of Calcutta you go Kolkata, you find you are not getting any A. So similarly, the R value in Western countries, the R value in India, neither the traffic moves faster, neither the R value moves faster. Therefore, all the more reason we should have our own data, we should have our own circumstances, we should know our own pitch. Even the cricket captain takes the pitch into consideration. The fast bowlers from West do not bowl fast in Indian pitches earlier times, because they were slow. Similarly, those things do not apply, and the data is also substantiating that. They have still got 10 times more mortality than Indian and Asian countries, which as the start, because there the elderly population, there people are not so crowded. We have got 10 times more population density. So all these are known as social epidemiology, which is more important in communicable disease than mathematical epidemiology.
Sir, can you please comment on the seriousness of the present pandemic situation with respect to the infection fatality rate with respect to other major public health burdens of our country?
Exactly. This infection fatality rate in the Western countries also it was highly exaggerated in the beginning. And in the first 3-4 months of the pandemic, even a paper in Lancet said the infection fatality rate of COVID may be as high as 20%. It's a published paper because actually the infection fatality is calculated by the number of people infected and out of them how many died. Numerator is the number of deaths divided by number of people infected. That shows the fatality. So initially Italy, particularly when it hit Italy, it hit the nursing homes, the elderly population, and the average age, median age of people who died in Italy was 80 years. So you can imagine 80 years people, any infection, a common cold kills 8%. So that denominator was the hospital cases, or they did not do any community survey ki how many had got subclinical infection. So initially fatality rate was very 5%, 10%, right up to 20%. Then most of the initial models were made on those figures. Then subsequently it was John Ionitz from Stanford University and Jay Bhattacharya from Stanford University. They did some sero surveys in California, Santa Clara, and even in a small sample, they found a large number, 30, 40 times having subclinical infection without knowing. So that brought down the infection fatality rate to almost 0.3%, 0.33%. And then subsequently, John Ioannidis he did a meta-analysis, and in the WHO journal also, it has been now accepted as 0.27 or 0.3%. And in fact, that is for the countries, particularly developed countries where they have a higher age and they have got a little more obesity. Obesity also is coming out as a major risk factor. We did a study in our steel corporation just after the first wave. We found a seroprevalence of 35% at the first wave, and from that number of deaths and all that, we calculated our infection fatality rate at 0.17 and subsequently 0.07, 0.1. So in Indian population, younger population, it was 0.1 to 0.3, 0.5 is the global infection fatality rate. That is taking all the infections. Like if you say 70% after the first wave, 67% of the people got antibodies. That comes to 90 crores Indians were infected, 90 crores. And the mortality was just 3-4 lakhs that time. That gives the infection fatality rate of 0.05%. You see, 90 crores, even the global data set doesn't show 90 crores. As on today, 56 or 57 crores people are infected globally. But in India itself, there are 90 crores people who are already infected. They don't know about it. So that is the futility of just doing contact tracing and all. They are only helpful in the initial stages when you try to stem it in the bud. But once it spreads, then you just can't run after a disease which is very mild, which is mostly asymptomatic. You have waste of resources and unnecessarily creating panic. And compared to other diseases, yes, as you said, that's a very important question, particularly in our country. Like we can say in our country, it may be 0.1% infection fatality rate, and that is also across all ages. In the child, just one child or two child in 1 million infected child will die of COVID, and that one or two child also will be having some comorbidity. So infection fatality rate in the child is almost zero for a healthy child. It is survival is 99.9973 in a below 18 years old. Up to 69 years of age, the survival from COVID infection is 99.5. 99.5. 0.5% is the mortality in a 69-year-old. And in a young person, it is 0.0001 or something like that. Whereas for other diseases, like tuberculosis kills every day 1,400. Every day we are losing more than 2,000 children, different preventable diseases. 2,000 children are dying every year. Now 20 cases of COVID, we are getting death, and that too with comorbidity. 2,000 children are dying, we are not bothered. We are bothered of not a single child is dying of COVID. We are bothered that we will save the child from COVID. So you see, it is not only public health is about money also, resources also. It is balancing of health priorities. We are having children dying. Now the UNICEF says because of this lockdown and this malnutrition will increase, about 4,000 children will die daily in India, poor children. So, and children are dying now of other obesity and other things. In middle class children, they have found obesity has increased during the lockdown period. Sedentary habits have increased. So this will be killers in the long run. So these are a major burdens, and for that we have not got very accurate data as for COVID, which has got a mortality rate almost negligible. Particularly, we have got other communicable disease, not a single communicable disease has got lower mortality than COVID. Dengue we have got. I was seeing dengue for the past 5 months, they have not updated the data in the Ministry of Health and Family Welfare, which is a dengue is a major killer in India. The data is not up to date. And here we are, every 24 hours, we are having COVID update. So this is something which is not stands to logic, common sense, or science.
So, sir, mathematical models that were designed in relation to this pandemic have failed miserably. So, the first question is that were they exaggerated? And secondly, you have shown in one of your recent articles that the data from the World Health Organization also shows that these models have failed. So, can you tell us on what basis were these models created, or rather, who created them?
These models, actually, in the best of the models, are academic exercises. They should not be taken as guiding policy, because the best models have a shelf life of 2 weeks only. Those who are serious modelers, they themselves will say that best models have got a shelf life of after 2 weeks. You have to update the model because things change. It is like a game of chess. Even the best grandmasters cannot predict more than 3 moves. I was just reading a book by Kasparov, the former world chess champion. He says whenever people interview me, they think grandmasters can think 20 moves in advance. He says no grandmaster can think more than 3 moves in advance, because so many permutation combinations other chesses move. So exactly this is what happens in communicable disease dynamics. You cannot make a model which will last more than 2 weeks, because as I said, R0 changes, and R0 is reproduction rate is different in Western countries, it is different in developing countries, the population densities are different, then people get infected, and then so it doesn't, it's a theoretical, but however, it makes the career of scientists, it makes the career of politicians also, because if they make a mathematical model which will predict very high deaths, and that deaths will never take place, they will say that all our measures have helped it. So the public imagination, public thinks the mathematics is exact. Mathematics, it is garbage out. So if you take wrong inputs, the mathematical models cause more harm than good. In fact, I have been doing peer review of mathematical models from journals. A few papers came to me and I found those shortcomings. I sent it back, and I knew some of the people who make these models. I told them that next time there's a pandemic, all modelers should be quarantined at the start of a pandemic, and they should be released after the pandemic. Otherwise, they cause more harm than good. So that is, and they may doing it that they sometimes it may be partly ignorance, not knowing the nuances, not knowing the finer details, not knowing the social. And you will be surprised to know this lockdown model, this social distancing model, they are mathematical models. They have been based on the high school project of a scientist's daughter. In 2015, she did a high school computer project to control influenza, closure of school. So they took the people as inert units, but people are social beings. They are not inert. They mix. They cannot isolate. You cannot sanitize. So these models were based on a high school project of a daughter of a government scientist in USA, and then they made the computer simulation. If they do social distancing, if they do lockdown, so many cases will come down. But in actual practice, it doesn't happen like that. So these models are good for learning processes, for identify these are the factors. But everybody, I call them mouse click epidemiologists. Like epidemiology, in our time, we used to go to visit the house, we see the local conditions, that social epidemiology. Then came the armchair epidemiology, sitting and giving this advice on panel and other things without going to the side. Now we have got the mouse click epidemiologists who just take data and they just feed it and they click the mouse and outputs comes out. So until unless you combine them, see the living conditions in India. Many people, middle class people or rich people in India, they have never seen a slum. They don't know that how many people stay. So model will not work there. That will work in there which has been in other country where the population density is less. So model can be, you have to see the context of the model. Model cannot be applied. The same model will not work. You take a Mercedes and you cannot drive in a slum in a Mercedes. You can drive on the highway. So these models are also like that. They can work in different TA, but it's a very complicated thing. It's not an easy thing, and we have tried to, amateurist and simplistic approach has caused more harm.
So when such projections are being made in the public domain, for example, in such modeling, should not there be any declaration of conflict of interest?
They have declared, I think the latest model which they made, they declared that it is funded by Bill and Melinda Gates and WHO and Gilead or something. They are declaring it, but who reads the small print? It is something you buy an insurance and you are not reading the small print. So models, they just make those, so they do declare, but they know nobody is going to read that except you and me.
So, Peter Doshi has written in an article that the trials of the vaccine have been jeopardized by starting universal vaccination.
Exactly. I mentioned it. I think I said that you have to have a control group. That is the basic of all trial. That uncontaminated group, and there is no ethical issue if non-vaccinating the people who have recovered from natural infection. There is no, in fact, there is an ethical issue of giving an unknown thing to a person who will not benefit. And now the evidence shows that there is no extra benefit of a person who has recovered, and particularly in a young person. So Peter Doshi is very right, and he was, I think, he was deplatformed from YouTube and other things.
So,
Because you see, that way I am finding BMJ is one of the editors of BMJ. So BMJ is one journal which has really maintained some semblance of scientific integrity. So I have regards for Peter Doshi, I have regards for the BMJ.
so finally, summing up today's discussion, the last question is that do you think that the COVID vaccines are necessary at all and safe for the population in general and for the children in particular?
This is a question which nobody can answer in the long term safety because nobody has data. So if anybody claims that it is safe, particularly in the long run, particularly in children, I am very concerned about children because if a person who is 70, 80, 60, there long term, there is hardly any fruitful years left. I mean, person has comorbidity, his chances of mortality may be more, vaccine adverse effect may be less. But in a child, suppose there is some adverse effect, say 5 years down the line, 3 years down the line, the child has a whole life to lead. And now most concerning is this myocarditis because it is a matter of heart has to last your lifetime. So definitely this vaccine, I don't understand what was the emergency for a disease which has a mortality 0.3%. And particularly in children, the mortality is 0.001%. For a healthy child, it is almost zero. You see, if a disease, simple common sense, you don't go into mathematical model to calculate the risk benefit. You ask a simple person, if a risk of disease like smallpox, the mortality was 30%. 30% was the mortality from smallpox. Vaccine, I said, okay, take the vaccine, even if there is a adverse effect of 5% of the vaccine, because 30%, 5 you can see. But here, when the mortality is unknown from the vaccine, long-term side effect is unknown from the vaccine, and the mortality is very, very minimal. So it doesn't work out. I mean, vaccine, and now you see the vaccine is not working also because If you see the countries which are very high vaccinated, we have got second booster in Israel. They are having post vaccination, they are having more surges of cases and even deaths also. Similarly, happening with Taiwan, Australia, New Zealand. Most of the countries are having, in Japan, you see, are having more than 1 lakh cases today. The country of just 12 crores, we have got 140 crores, and we are just having 15-20,000 cases and 30-40 deaths. They are just 12 crore, they are having more than 1 lakh cases and 60-70 deaths. And why? Because they have got high vaccination coverage, 70-80%, Japan. And similarly, Malaysia, they are having also second booster. And we are, because we are very dense country, so population immunity, the natural immunity is saving us. So when the natural immunity is saving us, and now the studies show, the vaccine I think was not required. Even if required, we could have done focused protection for vaccinating only the elderly and people with comorbidity, perhaps children also, but at the advice of the consulting pediatrician, family pediatrician. If a child is very obese, if a child has got leukemia, child has got some other comorbidity, each individual case across the board, mass vaccination can be hazardous. There have been anecdotal deaths also. There have been long-term side effects we do not know. So definitely vaccination as a public health policy for a disease with a so low mortality. The fear factor has been more than the actual mortality. You see, every day we lose 500 young people from road traffic accidents. 500, and so many gets handicapped for life. We are talking of hardly any child dies, but the parent will give a birthday present, a new car or a new bike to a 18-year-old rather than letting the child go out to school. For COVID, they are afraid of COVID much more than traffic accidents. If I am a parent, I am more worried that my child should be not indulge in rash driving. So the vaccine is, I think, the mass vaccination. I am my reservations about mass vaccination.
Thank you, sir, for giving us your valuable time. And we, on behalf of People's Alliance for Public Health, are interested to work with you in the near future.
Thank you. It's a pleasure. Look forward. Thank you.